All right, this is our part 2 of the female reproductive system. So it's part 2. So be sure you have your notes again. The first thing here is it's already filled in for you, is the menstrual cycle. Pertains to the changes in the endometrium of a non-pregnant female. The stratum functionalis of the endometrium is shed. You can see right here, this is showing the sloughing off of the endometrial lining here, and even over here. It says menstrual flow, menstrual phase, about the 1 through 5 days there. The ovarian cycle on top, the monthly events associated with the maturation of an ovum. So it shows what happens along the time of a month time frame. And your days are down here at the bottom, 1 through 28, because most books will use a 28-day cycle. Now here we go. Gonadotropin releasing factor from the hypothalamus regulates both cycles. Okay, the ovarian cycle and the proliferative phase cycle leading to the menstrual cycle. Stimulates the release of follicle stimulating hormone from the luteinizing hormone. Here's luteinizing, here's the blue line. From the adenohypophysis. These are your two gonadotropins, FSH and luteinizing hormone. So the first blank is FSH, that's follicle stimulating hormone. Stimulates the development of ovarian follicular cells and their secretion of estrogen. So it's going to stimulate the development of that egg, and in doing so, these follicular cells that are around the egg are going to be increasing in numbers. And as they increase in numbers, more and more hormones are secreted. Luteinizing hormone, the second blank, LH, is luteinizing hormone, stimulates maturation of the follicles and brings about ovulation. And we'll see that ovulation occurs on day 14 of a 28-day cycle. Stimulates production of estrogens and progesterones. There's your estrogens and your progesterone levels. And stimulates the production of relaxin. Relaxin says pubic symphysis cartilage. Relaxin was named that way because it softens or relaxes the pubic symphysis cartilage on the front of the female's pelvis to help assist in the reshaping of the birth canal during childbirth. So it's not a stiff structure. It can be stretched a little bit and allow the fetus to leave. Now another blank, estrogen, ESTROGEN, responsible for the development and maintenance of, I listed several things: female reproductive structures, the ovaries, the uterus, the vagina, secondary sex characteristics, mammary glands, less body hair, less facial hair, voice is different, a little bit higher pitched, the breast, the endometrial lining of the uterus, controls fluid and electrolyte balance, and increases protein anabolism. So estrogen has a lot of functions. Ovulation is going to result in an increase in progesterone levels, which we'll see in just a little bit. And that's going to inhibit gonadotropin releasing factor, which stops eggs being matured. You can see from this picture here, and we'll talk about it again, but luteinizing hormone is going to cause ovulation to occur. And when the egg leaves the vesicular follicle and all that's left behind are the follicular cells, there's going to be a reversal in the most predominant hormone produced by those follicular cells. You see estrogen begins to fall and progesterone levels rise. So prior to ovulation, estrogen levels are higher than progesterone. After ovulation, progesterone levels are higher than estrogen. And the progesterone is there to help continue or complete the development of the uterine lining. So we look back over here. Menstrual cycle says 24 to 35 days, okay, with an average of 28 days. And most books will have an average of 28. The menstrual cycle, the monthly discharge of 25 to 65 milliliters of blood, tissue fluid, mucus, and epithelial cells. So that stratum functionalis is sloughing off. Remember, the functionalis is going to slough off, and it'll be built up a new one the next month. Caused by a sudden drop in estrogen and progesterone levels, and lasts for about 5 days. So again, you can see that once the estrogen and progesterone start to drop at the end of this picture, it's going to be the end of this picture also. The levels drop and menstrual cycle starts. The stratum functionalis starts to slough off, and it even lasts for the first few days. The stratum functionalis degenerates, the uterine glands discharge their contents and collapse. The flows from the uterine cavity through the cervix, the vagina to the exterior. Flow lasts for approximately 5 days. That's what they usually say here, about 5 days, until only the stratum basale is left. Now that's supposed to be what's left, stratum basale. Meanwhile, back at the ovaries, back up here, while menstrual cycle is still going on, 20 to 25 primary follicles are called primary because the egg, the haploid egg, has one layer, basically, of follicular cells around it. Begin to develop. Okay, so that means that there's going to be more than one layer of follicular cells. That pushes it to a secondary follicle. To the effects of follicle-stimulating hormone. The result, low levels of estrogen are produced because more follicular cells are going to be produced, and the follicular cells are going to produce estrogen. Don't worry about the zona pellucida over the ovary. I'm not going to be worried too much about that. After 4 to 5 days during the menstrual cycle, the follicles have developed into secondary follicles. And you can see that's what it is. About day 5, there's your secondary follicles. Secondary follicles contain many follicular cells. There's a whole bunch of cells here now. And a fluid called follicular fluid. See that little space? Follicular. Second word is fluid, Fluid. And the fluid, the follicular fluid, forces the ovum to the side of the follicle. You can see it on this vesicular follicle here. Estrogen levels are raised, as are follicle-stimulating hormone levels. So they're both going to start to rise because of one reason, because these follicular cells are making more and more estrogen. Only one follicle will mature, the rest will degenerate. That happens to occur after ovulation. Biochemical signals are given off that stop the development of the eggs and the other vesicular follicles, and they degenerate and are reabsorbed by the female's body. Now, the post-ovulatory phase, or not sorry, the pre-ovulatory phase, before ovulation, that's going to be the follicular phase here. Last, right here, proliferative phase, lasts between day 6 to day 13. Proliferative phase, the uterine lining is being built up, proliferating, being built up. Follicle-stimulating hormone and luteinizing hormone stimulates the follicular cells to produce estrogens, and the endometrial lining is built up. Glands develop and the blood supply increases. It says besides this pre-ovulatory phase, and this phase is also called the proliferative phase, so you have a blank for that. Proliferative. Second word is phase, phase, due to the growth of the stratum functionalis. This lining is being built up. See, here's the basal down here, the darker pink. The lighter pink is the functionalis being built up. One of the approximately, also called the follicular phase due to the follicle-stimulating cells producing more estrogen, the dominant hormone, prior to ovulation. One follicle of the 20, so about 20 of these follicles are going to be developing into a vesicular follicle. It says vesicular or tertiary follicle, which will be ready for ovulation. During this development, the follicle increases estrogen production because of the follicular cells. Follicle-stimulating hormone was the dominant hormone in the early pre-ovulatory phase. So look at this, follicle-stimulating before ovulation. Luteinizing hormone peaks real quickly, is the dominant hormone close to the time of ovulation and is secreted in higher levels. It peaks and is given the credit for ovulation. Rupture of the Graafian follicle, or rupture of the vesicular follicle, that's what its new name is called ovulation. So ovulation, rupture of the vesicular follicle, and release of the ovum. This occurs on day 14 of a 28-day cycle. So luteinizing hormone peaked on day 14, ovulation occurred. An increase in estrogen inhibits gonadotropin releasing factor, therefore follicle-stimulating hormone is inhibited also. luteinizing hormone secretion increases. As follicle-stimulating hormone is inhibited and luteinizing and estrogens increase, then ovulation occurs. That's what's going to cause this ovulation. After ovulation, the Graafian follicle, the vesicular follicle, collapses. And it collapses right here and becomes the corpus hemorrhagicum, which we don't have here, but the cells enlarge to form the corpus luteum. corpusluteum. And the corpus luteum is what's going to produce progesterone and estrogens for a while. The post-ovulatory phase, also called the secretory phase here, same thing, lasts from day 15 to day 28 in a 28-day cycle. The time between ovulation and when menstruation starts again. Luteinizing hormone stimulates the development of the corpus luteum. The corpus luteum secretes estrogens and progesterone. Well, again, we can see this, that after ovulation, the predominant hormone is going to be progesterone. So your blank there is progesterone, progesterone. It's what's responsible for the continuation of this stratum functionalis being built up, the uterine lining being prepared. So it says prepares the endometrium for implantation of a fertilized ovum. The endometrium is ready about 1 week after ovulation. So I have in your notes, follicle-stimulating hormone secretion decreases, that should be decreases, and luteinizing hormone secretion decreases also. The dominant hormone is progesterone. That's what's going to finish this off, finish off the development of the uterine lining there, the endometrium. So we have some questions here, or some statements. If fertilization and implantation do not occur, then the rising levels of estrogen and progesterone from the corpus luteum inhibit gonadotropin-releasing factor and luteinizing hormone. So the rising levels of estrogen and progesterone from the corpus luteum inhibit gonadotropin-releasing factor. The corpus luteum degenerates to become the corpus albicans, corpus, as first word, albicans, albicans, and estrogen and progesterone levels decrease. So once it degenerates into the corpus albicans, the levels are going to fall. See, they're falling here. Low estrogen and progesterone levels initiate another menstrual cycle. Gonadotropin releasing factor levels increase and a new ovarian cycle starts. Now, if fertilization and implantation do occur, let's go back and see what happens if they do. The corpus luteum is maintained for 8 to 10 weeks. This is by human chorionic gonadotropin. HCG is human, H-U-M-A-N, chorionic, I think it's C-H-O-R-O-N-I-C, gonadotropin, G-O-N-A-D-O-T-R-O-P-I-N, they just abbreviated HCG, a hormone produced by the developing placenta. And that's what's going to be in the bloodstream, and it's also going to be in urine, and that's what those pregnancy tests are picking up, is the presence of human chorionic gonadotropin in the female's urine. The placenta secretes estrogen and progesterone in greater amounts than the corpus luteum, and so it'll take over the production of the hormones. Estrogen supports the pregnancy, progesterone supports pregnancy and breast development, and you have a blank. The first blank is menarche, M-E-N-A-R-C-H-E. This is the first menses, the first menstrual cycle. Menopause, M-E-N-O-P-A-U-S-E, is the last menses, the last menstrual cycle. And the climacteric, C-L-I-M-A-C-T-E-R-I-C, when menstrual cycles become less frequent, around 40 to 50 years old. That's because the female's reproductive system has been responding to hormonal fluctuations for, probably somewhere around 20 to 30 years. The ovaries fail to respond to gonadotropic hormones, and you end up getting hot flashes, sweating, emotional instability. So when you hear about somebody reaching menopause, that's when you have these problems. Now, birth control. Here's some birth control methods. Methods used to prevent the union of a sperm with the mature ovum. Well, I have them kind of put out here. These are implants up here at the top. Like a Norplant, there is a syringe they use to implant little cylinders that secrete estrogen up into your armpits so that you never release an egg. And it stays there for several months. IUD is intrauterine device. These are placed in the uterus to irritate the uterine lining to prevent a zygote from implanting in the endometrium. So they irritate the lining constantly. Here's sterilization. This could be a cutting of the ductus deferens and tying the ends off, or it could be a cutting of the uterine tube or fallopian tube and tying the ends off. They can tie them or cauterize them. And so, less than 1 pregnancy per 100 if you use these methods. A little less dependable. There's some injections that last for 3 months. It's a hormonal injection that will last for around 3 months. Here's the pill. You see that it's got a failure rate too, but it has estrogen levels, and then you have some placebos that cause your menstrual cycle to occur. Here's a patch. It's like a hormonal patch. Here's a vaginal ring that is inserted, and it goes up into the vagina, and kind of the cervix is in the middle here, so it kind of is in the vagina there. Here's a diaphragm which covers the cervix, and you use this spermicidal cream down here with this diaphragm to help prevent or block sperm from getting past here to the cervix. Not the best method. A male condom. This is for the male to put on the penis to trap the semen in this little reservoir here. There's a female condom that inserts in the vagina. Here's a cervical cap. It's like a diaphragm, but it pops over the cervix. It kind of attaches to the cervix, and you use a spermicide with that also. Here's a sponge. These sponges, you moisten with water, and it makes a foam, which is a spermicide foam that stays in the vagina. Here's I think this is supposed to be the temperature chart here for knowing when you ovulate, and you don't have sex right before and right after you ovulate so that you don't get pregnant. That's got a certain amount of leeway there that is not real dependable. And then just using a spermicide is not very dependable either, because sperm can make it past that into the female's reproductive tract without being killed by the spermicide. All right, that's as far as we're going to go on the second part of the female reproductive tract.